Good afternoon, Susan. I'm just going to check my audio and video.
But I'm not fine, so I just sent you a text. My audio is not good.
Okay.
Oh, and we can hear you.
All right. That's the first time today anything's worked, so that's good. Looks like we have everybody. So I will call to order the Green Mountain Care Board's hearing of July 10th, 2024. We have two agenda items today. The first one is a revised order regarding delegation of authorities here at the Care Board. And the second one, we're joined by the folks from VPQHC, who will provide some information on the hospital quality. And we thank you all for being here again with us and walking us through your presentation. First, I'll turn to the meeting minutes from Monday, July 8th. I'll move to approve the minutes.
I'll second.
And all in favor, please say aye.
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 And the minutes are approved. Susan, is your audio good enough to do the executive director report, or do you want to pass this week?
Can you hear me now?
Yes.
Okay. It will be brief. First, I just wanted to remind folks about the community engagement work we're doing per Act 167 in hospital transformation. We had an enormously successful meeting last night up in Newport. Successful because we heard so many voices from that community and we thank them. And it was a wonderful meeting, and it was great to see all the folks up there tonight. Can you still hear me?
Yes.
Okay. Tonight we'll be in St. Albans, and then tomorrow night we're going to St. Johnsbury. Please check our website for more information on these meetings. And thank you all to the communities we're visiting. We're accepting public comments on the community. Okay, I'm going to stop and go to you, Owen. If you want to share anything else, go ahead. And folks should check our public comment page.
Sure, I can try and take it over. So we do have public comment open on hospital transformation in the Act 167 work. We did receive a lot of comment and thoughts last night on Newport. So please, anyone who has interest in providing additional feedback, go ahead and submit additional comment via our website. And we hope more people can continue to attend the hearings. They're really productive. So with that, I'll turn it to Ms. Degree, our Health Policy Project Director.
Thank you, Chair Foster. This should be relatively quick today. I just wanted to talk to the board briefly about some delegation of authorities as it relates to Act 167. And now that the state of Vermont has been formally accepted into the AHEAD model, talking about delegation of authority for negotiations related to subsequent agreements. So I'm going to share my screen. And can you confirm that you can see that? It's a split screen, so you should be seeing two sets of things. Okay. So there was an initial delegation of authority order issued in June of 2022. That was revised to include Chair Foster in September of 2022. That followed the 2022 legislation related to Act 167. This revision here, which is the Word document, and I will make that bigger so you can see it. It has been updated to more accurately reflect and lay out sort of board participation in the kind of subcategories of Act 167. And again, as we sort of enter into AHEAD negotiations, now that the state has been officially accepted into the model. So as you can see, the old version had we've split it to more accurately reflect. So now we have a section specifically to community engagement and hospital sustainability that names Chair Foster and Board Member Holmes, and then the activities related to a subsequent agreement are delegated to Board Member Lunge and Board Member Merman. That's all I have for you. We do need a vote on this item so that it can be posted to our website. But other than that, happy to answer any questions you all might have.
I don't have any questions or comments, and other than to thank Dr. Merman and Member Lunge for taking on this work and responsibility. And I'm ready. I can make the motion, but I'll open it up to any other board member comment or questions. Okay, so I'll make the motion, and then pursuant to our normal process, I'll take any public comment and open up to the board. So I move that we revise the delegation of authorities as described in the delegation memo presented by Ms. Degree.
I can second.
Any other board member comment or discussion? And is there any public comment? All those in favor of the motion, please say aye.
Aye. Aye.
Aye.
Aye.
Aye. And the motion carries unanimously. Thank you very much, Ms. Degree.
Thank you all.
Thanks. Next, I'll turn it to Elena Barabee, our Director of Health Systems Finance, and for the presentation from VPQHC.
Great. Thank you all. So I'm just going to pass it right over to Hillary Wolfley, and I will welcome you and look forward to your presentation.
Thanks, Elena. Allie's going to be bringing up the slides. Thank you so much for having us today. My name is Hillary Wolfley. I'm the Executive Director of the Vermont Program for Quality in Healthcare. And we're going to be presenting on the Vermont hospital quality landscape and providing an overview of VPQHC's hospital quality programs. Oh, next slide. Sorry, I'm not used to that. Thank you. So we've included an outline of the presentation here. So I'll just open quickly with an overview and orientation to VPQHC. We'll then jump into just a one slide kind of overview of key organizations, standards, resources, and entities that provide oversight of hospital quality and patient safety in Vermont. We'll then jump into the bulk of the presentation, which is an overview of VPQ's hospital quality programs, and then we'll wrap up with some next steps and recommendations. Next slide, next slide. Thank you. So about VPQHC, VPQ is a 501c3 nonprofit organization designated by the Vermont legislature in 1988 as an independent non-regulatory peer review committee. Our mission is to improve the healthcare quality in Vermont by studying the system and making it work better. Next slide, please. We have 9.6 FTEs, and they're included here on this slide. We will be adding a few positions in the near future, including a suicide prevention initiatives, quality improvement specialist, and coming this fall, we're really excited that the Vermont Child Psychiatry Access Program and their 3 staff members will be coming to join VPQHC as well. And in addition to that, we contract with 10 to 15 consultants annually. Next slide. No, that's good. VPQHC is overseen by a board of directors, and I've included them here. Many of the names may look familiar to you. And these seats on the board are statutorily mandated. Next slide. So now we're going to move on to just a quick slide providing some key resources and information on organizations that provide regulatory and quality oversight for Vermont hospitals. So there are many organizations and programs nationally and in Vermont that work to ensure specific quality standards are met and that quality of care is delivered across Vermont hospitals. I've included a few here with links, and we'll be diving into some of them during the presentation today. So the first is Act 53, the Vermont Hospital Report Card. There's also the Patient Safety Surveillance and Improvement System, the Vermont Division of Licensing and Protection, the Survey and Certification Department, the Joint Commission. This is an organization that accredits healthcare organizations, and 6 of our hospitals have Joint Commission accreditation. DNVGL is another accrediting organization, and one of our Vermont hospitals has DNVGL accreditation, and then CMS Hospital Compare, which displays comparative hospital performance data. So we're not going to go into this in depth today, but we've included links in case you would like to dive in deeper and explore this a little bit more. Next slide, please. So the bulk of the presentation today, an overview of VPQ's hospital quality programs. So first up is 9416. This is our core funding contract, and we call it 9416 because it is the statute that established VPQHC as the statewide quality assurance organization. This contract is overseen by the Vermont Department of Health and is renegotiated every 2 years. And it has a specific set of activities, deliverables, and performance measures that VPQHC must meet to be in compliance with the agreement. Activities in this contract are centered on the pillars included here in the boxes, in the blue boxes. And a lot of our projects are centered under the 9416 contract on hospitals and quality improvement. And we'll be going over some of those today. So the Hospital Quality Directors Network, the Hospital Care Management Directors Network, the Vermont Hospital Peer Review Network, and we also provide technical assistance to hospitals to support them with reporting their surgical site infection data and their healthcare associated infection data into the National Healthcare Safety Network. And new this year, we'll be offering a Change Management 101 training to all healthcare providers. Next slide, please. So the Vermont Peer Review Network under 9416, this is a program that's been running since 2001. And the purpose is to support small rural hospitals with accessing peer reviewers. The program is voluntary and the pool of reviewers is updated every 2 years. And over the past year, we've convened a peer review expansion work group to look at strengthening the current program and also expanding to non-hospital based sites. There are many states with statewide peer review programs, other rural states. So we've been connecting with them. So Maine, New Hampshire, Illinois, Texas, and Idaho to learn a little bit more about how they run their programs and how they're structured, and to consider elements we might want to incorporate into our Vermont-based program. So we're in the process of putting together a redesign proposal, and there may be some changes to this program in the future. Next slide, please. Okay, and now I'm going to pass it to Patrice Knapp, who will be going over the Hospital Quality and Care Management Directors Networks that VPQHC runs under 9416. Then she'll also segue us away from our work under 9416 to provide an overview of the Vermont CDC VDH Health Equity Initiative.
Thank you, Hillary. Good afternoon, everyone. My name is Patrice Knapp. I serve VPQHC as a strategic quality improvement consultant. I am an RN. I'm certified in healthcare quality and have nearly 13 years of quality management experience in Vermont. I'd like to share with you the structure and function of the Care Management and Quality Director Affinity Networks. The purpose of these networks is to share best practices and offer relationship building and provide relevant topics of interest. On the care management side of the slide, you can see recent presentations from regional subject matter experts. The focus is on community resources available to patients. Hospital care managers are instrumental in referring patients and helping them navigate and coordinate care after leaving the hospital. The selection of presentations has yielded really robust discussions, sharing of challenges and solutions, as well as increasing awareness of available resources. The Quality Director Network topics focus on patient safety, regulatory requirements, performance improvement, and policy sharing. Quality directors frequently provide presentations of their own internal quality improvement and safety initiatives, And we also look for outside subject matter experts on topics important to the quality director role. Quality directors have the opportunity to share questions, find solutions, and learn from one another. Although these are separate affinity groups, we often combine these members when topics overlap, because quality directors and care managers interface frequently in the hospital environment on multidisciplinary teams. Next slide, please. Next, I'd like to present the Vermont CDC VDH Health Equity Initiative. The purpose of this grant-funded opportunity is to improve knowledge among hospital staff of the impacts of biases in healthcare delivery and reduce healthcare disparities among racial and ethnic minorities, LGBTQIA+ persons, and/or persons living with disabilities. To meet these goals, there are 3 focus areas: hospital quality improvement projects, cohort training, and patient focus groups. The hospital QI projects were completed by 14 hospital teams based on the hospital's Health Equity Organizational Assessment, which is authored by the Eastern Quality Improvement Collaborative, using Plan, Do, Study, Act performance improvement methodology. Based on the assessment, many of the participating hospitals chose to focus on demographic data collection. This would be the social determinants of health, sexual orientation and gender identity, and race, ethnicity, and language. These are fundamental to understanding the population served. Training and education was also a common focus around cultural bias, policies, language, and interpreter access as well. The advanced cohort training was open to participants who have completed 2 foundational trainings: provider bias awareness and structural competence and cultural humility training to address disparities and inequities. These trainings were held in 6 4-hour sessions, and 6 hospitals were represented. What was unique about these sessions was the way that Dr. Avila wove didactic content with real patient documentaries and vignettes, describing very compelling stories of lived experience within the healthcare system related to health equity. What I found to be the most overarching tenet was the information on language access and communication, effective communication. It really all starts there. If you cannot communicate effectively, the patient and the family cannot be active participants in their healthcare needs. Also, the patient rights section focused on the rights of patients to have culturally appropriate care, disability accommodations, and translation services. All of these are challenges that Vermont hospitals face. The patient focus groups were conducted through various modalities to assure a conclusion. These were offered through online survey, in-person, or individual interviews. Recruitment of patients from each hospital area was accomplished via cultural brokers, social media, community case managers, and from the hospitals themselves. In many languages other than English were also represented: Nepali, Urdu, Arabic, Chinese, Spanish, Afghan, Burmese, and French. Several participants identified as having a disability requiring American Sign Language interpretation as well. In addition to white participants, Black, African American, Hispanic, Asian, American Indian, and Alaskan Native racial identities were represented. The output of the interviews is an individualized report for each of the 16 hospitals to increase awareness of disparities perceived in their patient population and to address concerns as opportunities for improvement. And I will pass to Allie, please.
Thank you, Patrice. Hello, my name is Allie Johnson. I am a quality improvement specialist for VPQ. Excuse me. Prior to my joining VPQ, I served in public health in cancer surveillance, epidemiology, and research for 25 years at the Department of Health. And I'm going to talk about two programs. The first is the Vermont Hospital Quality Framework. Vermont statute tasks at least 3 organizations with assessing the quality of healthcare delivered across the system. Of course, the Green Mountain Care Board, and Hillary mentioned Act 53, the hospital report cards, and the Vermont Department of Health. And the third is VPQHC. In January of 2022, with financial help from the Vermont Department of Health Office of Rural Health, we convened the Vermont Hospital Quality Framework to design a framework of meaningful metrics that provides relevant information and accurately reflects the hospital system's quality of care within the healthcare reform environment in Vermont. And I'm happy to say the work group represented many key sectors in our state's healthcare system: government, insurers, hospitals, providers, researchers, and consumers. We modeled our process, you can see that in the graphic, on the National Quality Forum's process for drafting the 2018 recommendations from the Measure Applications Partnership Rural Health Work Group. "55 individuals representing 25 organizations, including many people here from the Green Mountain Care Board, participated in 8 months of work group activity. The group drafted a charter to guide its work and invited 6 presentations by subject matter experts, including things like results-based accountability, to gain a shared understanding of quality measurement. 35 state and national resources are posted on our webpage. You can see the link at the bottom of the slide. We inventoried measures of hospital healthcare quality already being reported and monitored. The UVM Larner College of Medicine Health Disparities and Cultural Competence Group, led by the same Dr. Maria Mercedes Avila, who Patrice just mentioned, advised us on health equity measure selection. Based on 2 workgroup surveys, the Vermont Hospital Quality Framework was designed. 19 measures were selected and 14 recommendations were given. So we hope to continue to work to consolidate statewide quality reporting in a way that delivers reliable and high quality information for as many stakeholders as possible. We also hope to continue to collaborate with the Green Mountain Care Board and others to merge existing frameworks, dashboards, and scorecards to reduce duplicative reporting, to create a common understanding of quality and performance, and reduce overall reporting burden for providers. Now we'll talk about the Vermont Emergency Telepsychiatry Network, or VETN. Emergency department boarding of patients with mental health needs, as you know, is having negative impacts on patients, providers, and the hospital system. In Vermont, we know from VAHS data that 1 in 7 ED beds is occupied by a patient waiting for mental health care at any given time. Telepsychiatry can reduce the time these patients spend waiting evaluation and treatment and can enable EDs to offer more meaningful care. And so, excuse me. The VETN is a statewide system helping Vermont emergency departments provide timely psychiatric care via telehealth for people with mental health needs. Our advisory board of 31 individuals represents 7 key sectors. We have people with lived experience, advocates, telehealth experts, insurers, government representatives, project leaders, and providers and others who are involved in the continuum of care. The training portal is hosted by the Northeast Telehealth Resource Center, and we have 2 demonstration projects at Rutland Regional Medical Center and Northeast Vermont Regional Hospital. And I've put some data about the outcomes here and the startup costs in the slide. The RRMC project, connecting children and adolescents with Brattleboro Retreat clinicians, has had such success at their hospital that they've decided to continue the collaboration without any further grant funding. The NVRH project, which has a bigger scope, they implemented a whole new 24/7 emergency telepsychiatry service for patients of all ages. So I don't know if I mentioned, but in the Rutland Brattleboro Retreat collaboration, it's pediatric and adolescent patients connecting just 2 afternoons a week with the Brattleboro Retreat clinicians, and NVRH is 24/7 on call, any patient who needs it. So it was relatively costly to establish. And it's helping vulnerable people in the Northeast Kingdom access much needed care, and ED providers and staff are very satisfied with the service. I can also share that the project has been rigorously evaluated by a national firm, RTI International, and lots more quantitative and qualitative data are available on our webpage, which is listed below. And now I'll pass to Morgan.
Good afternoon, everyone. I'm Morgan Bedard. I'm a quality improvement specialist with VPQHC, and I joined VPQ this summer when I left my role as the Director of Quality and Performance Improvement at Central Vermont Medical Center. I am a certified professional in healthcare quality, and I will largely be supporting patient safety programming here at VPQ. So for an overview for the patient safety surveillance system, VPQ is contracted to administer the Patient Safety Surveillance Improvement System on behalf of the Vermont Department of Health. And the 3 primary components of this system are review of serious reportable events from the hospitals and ambulatory surgery centers across the state and monitoring for trends in these reportable events. We are supporting quality improvement efforts in disseminating best practices as they relate to patient safety. And we also provide training, technical support, and periodic on-site visits to support statutory compliance with the PSSIS requirements. To share a couple of highlights as we're continuously looking to improve our programs and processes, in the year ahead, we're looking to focus on supporting a shift to a more proactive approach to safety, where facilities in Vermont are learning from measures implemented by other facilities in the state, and then taking action on these learnings prior to a similar safety event occurring at their facilities. We already have the networking group established with the quality directors that Patrice mentioned, so the infrastructure for this is already in place. The second focus area in the year ahead is supporting facilities that have an over-engineered causal analysis process that goes over and above the statutory requirements to allow the existing quality review processes and tools that are already in place to be capitalized upon. And this will help reduce unnecessary expenditure of resources in response to these reportable events. In the table on the right, we're showing you the number of serious reportable events that have been submitted annually since 2020. And more details on the events, as well as more of a historical look back on the number of reports submitted, can be found in the 2023 annual report that's linked in this slide. I'm going to pass it now to my colleague, Mary McQuiggan.
Thank you, Morgan. Hi, I'm Mary McQuiggan. I'm the Director of Programs at VPQHC. I'm a licensed independent clinical social worker, and my background is in social work and inpatient psychiatry, and also working in schools. So I'm going to talk to you about the trauma responsive care trainings that we have been a project we've been managing for emergency department staff across the state. This project is really designed to address the immediate need of patients who are sitting in emergency departments or arriving at emergency departments in mental health crisis. We started this project in 2022 by by building an excellent team of trainers. Our team includes 2 trauma responsive care experts, as well as our peer support specialists with lived experience. And we've heard from all of our participants that being able to connect with the peer support specialist and hearing her story just really has had a huge impact on them. Allie, if you could move to the next slide, that'd be great. Thank you. So this project was built off of a training that Dr. Christian Pulcini, Dr. Haley McGowan, and their colleagues designed for staff at UVM-MC. We built the training team and then built off of that previous training to create the training that the trainers are now using. We've trained 12 out of 14 emergency departments. Last year, that was 122 hospital staff were trained. This year so far, we've trained 82 hospital staff, and we have over 70 people registered for the rest of the trainings this year. And we're returning to a lot of the same hospitals this year and a few hospitals that we did not see last year. We also, in 2024, early 2024, completed the Trauma Responsive Care Toolkit, which has resources and guidance for implementing trauma responsive care in the emergency department. And you can see some highlights on the side. We're very excited to be headed to CVMC tomorrow with the training if the weather is agreeable. And we have almost 50 people registered for that training, which is really exciting. And I believe I'm passing it back to Hillary.
Thanks, Mary. So I'm going to talk about the Medicare Beneficiary Quality Improvement Project, or MBQIP. MBQIP is a federal program created by the Health Resources and Services Administration to support critical access hospitals with quality reporting and improvement. VPQHC is the subcontractor to the State Office of Rural Health at the Vermont Department of Health to administer this program in Vermont. Nationally, there are 1,368 critical access hospitals, and of those hospitals, 1,360 participate in the MBQIP program. In Vermont, since the program started, we've had 100% participation across the Vermont critical access hospitals. Next slide, please. So MBQIP participation benefits include comparative reporting and rural relevant benchmarking, as well as access to technical assistance, support, and quality improvement resources. And historically, hospitals that are participating in the program have been required to work towards reporting all of the measures that are included in the MBQIP core measure set. And you can see a snapshot of the measure set here. There are going to be some changes to this measure set coming up in August of next year. And they've added a domain to the measure set as well as individual measures that are in the blue text. So those are the hospital commitment to health equity, safe use of opioids, the hybrid hospital-wide readmissions measure, social determinants of health screening, and social determinants of health screening positive. And then there is a final measure that's being added, and you see the arrow coming out of it, the Critical Access Hospital Quality Infrastructure Annual Assessment. And this is interesting. It's something that is new and was launched by the federal partners just this past year. And 6 of the 8 Vermont critical access hospitals took this assessment this previous year. And it's really moving away from just focusing on measures, but also looking at infrastructure. And I've included a quote up at the top that they have in the introduction of the assessment saying, quality is not just measures, but infrastructure. A focus on quality is key to excellence in patient care. If leaders focus only on individual measures, they're bound to miss the mark. And I've included a link to the full report on this slide if you're interested in reading more. Next slide, please. The next program I'm going to provide an overview of, and this is the second to last, I promise, and we've even left some out, but I think this would be enough for today. The Suicide Prevention in Emergency Departments Quality Improvement Initiative. This is a program VPQHC has been running in partnership with the hospitals for the past few years. And as you can see on this slide, 65% of people who died by suicide interacted with health services within a year of death. 35% of those who died by suicide visited an ED within a year of death, and 24% had a mental health or suicide-related ED visit, and 11% visited an ED within a month of death. Also a pretty compelling statistic, and this was from a study and survey that was launched at the beginning of this initiative by a nurse that we partner with up at the University of Vermont Medical Center, that 78% of ED staff respondents indicated they had no previous suicide prevention training ever. And it's likely even higher than that, because in the 22% that make up the other part of this, it included respondents indicating, yes, they had taken training, or maybe they don't remember. Next slide, please. So there are evidence-based best practice interventions that can be delivered in the ED setting that research has shown can reduce death by suicide. The initiative that we've been running is a multi-year initiative, and I've outlined the activities here. And we've really taken a stepwise approach with the hospitals. I've included some highlights on the right. We've had 93 to 100% hospital enrollment in this program since it started. Over 300 emergency department providers have been trained in counseling on access to lethal means, and 100% of enrolled sites have made improvements to at least one of the following: safety planning approach, documentation auditing, suicide care policy review, observation processes, ligature resistance, suicide assessment protocols, and safe room guidelines. We have contracted with an evaluation consultant, and we will be working with them to put out a white paper on this. So we'll be happy to share that once it's been written. Next slide, please. And these are just some resources on suicide prevention in healthcare, and some program-specific resources that were developed through our work. Next slide. So this is the last program we'll be providing an overview of today, and that's the Emergency Department's Pediatric Comfort Kits Initiative. And Mary and Allie both spoke to the challenges and trends around lengths of stay in emergency departments across Vermont. And you can see in the statistic here, in Vermont, in a sample of 242 pediatric patients with primary mental health concerns, the median boarding time was 2.8 days. And you can read the full publication that we took the statistic from. I've linked to it here. And VPQHC has built and distributed 2,580 pediatric comfort kits to all hospitals across the state to mitigate the effects of boarding while more systematic and permanent solutions are found. This is spreading a program that exists at the University of Vermont Medical Center and using guidelines developed by Boston Children's Hospital. The kits have been very well received by hospitals, patients, and their caregivers. Next slide. So in summary, hospitals participate in multiple quality and patient safety related programs to continuously work towards a system that is safe, patient-centered, effective, efficient, timely, and equitable. Today, we mainly focused on the VPQHC hospital quality programs, and this is an inventory of those programs, so you can see kind of at a glance which hospitals are participating in the programs that we reviewed today. And we hope to be able to continue to build out this inventory to include other data and information that we have, like what EMRs the different hospitals use, and other quality related programs that hospitals participate in, not just those run by VPQHC. Next slide, please. Double next slide, actually. So some parting thoughts around next steps. So we've really valued and enjoyed the collaboration with the Green Mountain Care Board. We look forward to continuing that collaboration and meeting with Green Mountain Care Board staff and the Hospital Association and the Healthcare Advocates Office around quality. Some general landscape thoughts, quality landscape thoughts, the importance of continuing to align and coordinating to increase value and reduce administrative burden, building from existing structures and off of what is working well, to continue to support shared learning opportunities and drive resources to quality improvement initiatives. And then the point from the MBQIP slide that quality is not just measures, and a focus on quality is key to excellence in patient care. And this did get us thinking maybe there is a role for VPQ to develop and maintain a statewide inventory or strategic plan related to the hospital quality landscape to support bullet 1 around alignment and coordination. And 2 quotes around quality that we'll leave you with. Every system is perfectly designed to get the results it gets. If we want better outcomes, we need better systems. And then the second quote, I think, really just speaks to the essence of quality, and that is improving quality is about improving lives, reducing suffering, and helping people achieve their potential. Next slide. And that's it for us today. I've included all of our contact information here. Thank you so much. We've really appreciated the opportunity to speak to you all today, and we're happy to answer any questions.
Thank you all, and thanks for coming back and doing it again this year for us. I'll open it up to the other board members for any questions or comments they may have.
I'll go ahead and hop in. I had a couple of small questions on slide 17, and you don't have to pull it up, but it was about the participation in the telepsychiatry project. Could you speak just a little bit more about, you noted that 10 EDs use telepsych, and you noted 2 demo projects. Could you kind of distinguish those 2 in a different way? So just give us a little more qualitative information about the differences.
Sure, happy to. This is Allie again. This project was the result of a needs assessment we did prior to getting a 2-year $900,000 grant from SAMHSA. And in the needs assessment process and getting ready for the grant, we were kind of assessed the environment of, we asked EDs, what are you doing for ED telepsychiatry, if anything? And we found that basically there are 6 Dartmouth affiliated or owned or otherwise Dartmouth related hospitals that get care from Dartmouth Health. And there are the 2 demonstration sites I described. CVMC gets, I think, support from UVM. And then there are a few hospitals that don't yet have emergency telepsychiatry in the ED. UVM doesn't need it because they have psychiatrists on staff. And Rutland doesn't need adult telepsychiatry because, again, they have an inpatient adult unit that they can borrow clinicians from. So we initially went into this project, and the reason I mentioned the needs assessment is because we did an environmental scan of other states and best practice to try to work on this problem of patient boarding. And we found North Carolina stood out as an important model, and we met quite a bit with them to try to design our project similarly. They have more of a hub and spoke model where a centralized office of psychiatrists, and they offer it to mostly critical access hospitals in their state. We found that because we started this project after the pandemic had already started, telepsychiatry was already an established mode of care, that we had already, these hospitals already had things in motion, and we were already more of a patchwork than a hub and spoke model. And so we tried to use the short-lived federal funding to just raise the tide as much as we could for all of the hospitals. And you see on Hillary's slide that summarizes, and it shows nearly every hospital is involved in the project. That doesn't necessarily mean that they have an emergency telepsychiatry service, but they might have helped us in one of many ways, like by doing an assessment or providing best practice that we could put on our training portal. Does that answer the question?
Yes, thank you. That's very helpful. I appreciate it.
Great. Okay, thanks.
Hi, this is Dave Merman. I have a few questions. Just one other thing, since I'm an ED doc and I do work at CVMC, CVMC does have inpatient psychiatry and has 24-hour psychiatry coverage. So it's part of why they don't have telepsych.
Thank you. Thank you.
You're welcome. Yeah. So can I, on slide 18, you talked a little bit about reporting serious adverse events, and it looks sort of, 20, 21 were kind of weird years. And then beyond that, it's sort of steady-ish, maybe, fairly flat. And I'm just trying to figure out what that means. Is it flat, or or maybe it's up from what it was? Do people feel more comfortable reporting serious adverse events, and you're developing that sort of culture of feeling comfortable reporting quality challenges, or is it that we have, is it mixed with that with an improvement, or is it that we're really not getting much improvement? How do you interpret the data that's there?
That's a great question, Dr. Merman. And we've been following that, keeping our eye on it. And a few things that have come up with conversations with the hospitals and through their corrective action plans, and a few themes that we've noted, particularly since 2020, as hospitals are reporting an increased census and some an increased acuity. We're seeing an increased use of traveler staff. So that could involve both different training and orientation to the organization. And some report a different level of commitment to the care provided by traveler staff. That's not across the board, but that is something that we do here. And then another example of why this has increased, I can share, as it's in our annual report, is the primary bulk of events that we're seeing right now are falls with serious injury or death resulting in advanced stage hospital-acquired pressure injuries, so stage 3 and above. And hospitals have reported that they've increased their surveillance of these events. So for example, adding certified wound care nurses, and that's great in providing care to the patients, and it means that you're finding more of these pressure injuries. And pressure injuries did make up 50% of the events reported last year.
Do you have any ability to understand whether or not this is related to a lot of the challenges that hospitals have of boarding medical patients longer, patients that are sort of longer term stay patients in the hospital that would be more appropriately cared for in long-term care facilities? Is that anything that you can relate to this data?
Length of stay certainly plays into it, and as you can imagine, especially with pressure injuries. So one example of where we can see that is reporting between critical access hospitals, who do have a much shorter length of stay, versus the mid-sized and academic medical centers, where the length of stay can go on for weeks to months on end. And that is one of the metrics that we collect, is the date from admission versus the date that the event occurred or the injury occurred. So we can monitor the length of stay prior to the events being identified.
Thanks. The other question that I had from the slides is, there's slide 28, you had a large chart of various quality reporting for different hospitals, and I didn't get a chance to sort of digest it because it came up quickly, and I probably should have looked at it more carefully earlier, but I didn't notice it at that time, was that some hospitals are Joint Commission accredited and many are not. Are the nots because they're critical access hospitals and they don't fall under Joint Commission, or are there other reasons why a hospital wouldn't be a Joint Commission accredited hospital?
I might ask Patrice for your thoughts too. But those 8 that are not Joint Commission accredited are the critical access hospitals. And I know accreditation is quite expensive, but Patrice, do you have any other thoughts on that?
What I hear is it's the expense of it. They just can't afford it, and they're surveyed by CMS every year anyway. You know, so I think it seems adequate to them.
Great. Thank you.
And I will say, and I forgot to add, that one critical access hospital does have the DNVGL accreditation.
Thanks.
So I'll ask just a couple questions. I actually had the similar question about the Joint Commission accreditation, and I wonder if, just from your perspective, does that seem reasonable that the cost would be prohibitive and it's unnecessary because CMS does their annual reviews?
I think it's reality. I'm not sure it's reasonable, but that's what I'm hearing. You know, why aren't you? And the cost is prohibitive, even for the hospital, the mid-sized and large hospitals. A lot of it is based on volume too. But you know, CMS and Joint Commission are really working in tandem these days, and they are actually following up with the Joint Commission to make sure that the conditions of participation that are requirements of the CMS survey are actually being met to their satisfaction. So I think you know that CMS is not considered a lesser survey anymore. It used to be kind of minimal, not so much anymore. You know, they're really following the Joint Commission standards without making that a formal announcement.
Great. Okay. And I guess the second set of questions really involves around surgeries. So it would apply to hospitals that are doing surgeries. And I'm wondering, does VPQHC work with hospitals to review and benchmark data on surgical site infections, surgical complications, revision surgeries that may happen at a different hospital? How do we, you know, understand that type of data? And where would a patient who's considering having a surgery find those sorts of surgical outcome data? If you look at, you know, Care Compare, largely it's missing because of the small sample size. So I'm sort of wondering what VPQHC might have in terms of understanding these outcomes.
Well, I can start off, Morgan. We do support that under Act 53, the hospitals are required to report on their surgical site infections for hip, knees, and hysterectomies. If you go on the Vermont Department of Health website on the hospital report cards, they actually do show the number versus Care Compare. So you can find the numbers there. Beyond that, the only other program is the Patient Safety Program. And I don't know if Morgan, you want to speak to that?
There is a category of surgical events that would be included as a serious reportable event, such as a wrong site surgery, a retained foreign object, surgery on the wrong person or the wrong limb. So that would be a reportable event that would go through the patient safety surveillance process that requires a causal analysis and corrective action plan.
But that's confidential, right? I mean, patients don't have access to that information. So that's not something that's transparent. And I guess I'm more thinking about the types of surgeries where it just didn't go well, and now that patient has to go seek care from a different surgeon at a different hospital. And is there any tracking of that whatsoever?
Patrice, you're on mute.
Internally at hospitals, they typically will have a peer review mortality and morbidity committee. And those surgeries that are problematic or have poor outcomes are brought to the medical staff for review. And if they don't have the right types or enough surgeons, in the hospital, that's when they would use a peer review network to get an outside opinion on did we follow standard of care, best practice? Was there something preventable that we could do differently? And then you would go through the quality improvement process internally in your hospital. But we don't have access to that confidential information.
Okay. And I probably have asked you this before, but it's, it's certainly arising through some of the work that our Dr. Bruce Hammery is doing around community engagement and looking at some of the low volume data. So I'm just wondering if you all have a position on, I know it's very often some challenges to balance access and quality, and low volume allows for access, but in some cases it can compromise quality if there's not a minimum threshold met. And I'm just wondering if VPQHC has any thoughts on, establishing minimum thresholds where there is abundant literature that suggests that a minimum threshold should be met in terms of the volume of the surgical team, meeting a certain volume to have clinical accuracy, quality, all of those things. So just wondering what you all think about that.
I can't speak to the variances between hospitals, but there is a component of this that's baked right into the privileging process, where if you're going to be privileged for certain procedures, you need to complete a minimum number in order to become privileged and then re-privileged or credentialed at that facility. It's important to monitor low volume care complications. And a couple of important notes are that resources to do so by the hospitals are not limitless. So they need to be thoughtful with getting the most bang for their buck in terms of what they're looking at. The low volume events that are valuable to monitor at a critical access hospital will vary from a mid-sized hospital to then the academic medical center in the state. And then facilities need to be cautious with making improvements based on low volume events. So there could be a clinical complication that the patient's consented for that may or may not occur versus an error or a wrongdoing by a provider. Those are two different things. So the facilities need to be cautious about making knee-jerk systemic level changes based on one or a small number of events that may have occurred if it was an adverse outcome.
Okay, I appreciate that. And I thank you for all the hard work that you are doing and your presentation. And Hillary, just a huge shout out to you in your new role. Congratulations. So, yeah, thank you all.
May I contribute a little to the hospital report card conversation and answer? I was struggling to find my unmute. I did go through Care Compare, download data sets, go through data dictionaries, and make a, what do we call it, an inventory of several measures, thinking about which surgical related measures are available for which hospitals in an identified way. And so we could share that inventory. It is public records on our website. I know the chat feature is disabled, so I couldn't put it in the meeting chat, but it does show which hospitals report which measure, and it has a lot of hyperlinked information about where each measure comes from and how it's defined.
Great, thank you so much.
Mm-hmm.
Good afternoon, this is Tom. I've enjoyed the presentation and I've enjoyed the questions so far. One of the things that came up while listening, does anyone know what is the cost of participating with the Joint Commission? We're saying that it's too high, but what is the figure?
Well, it depends. It depends on the volume of your patient load. So CVMC pays $50,000-$70,000 or more to have a 3-year survey. Do you remember, Morgan, you've been in that budget, sooner than I had?
Yeah, that's the approximate fee for every 3 years that you pay for the on-site visit. You're paying for their travel, their hotel, their meals, and their time on site and writing up the report. There's also an additional annual fee on top of that. At Central Vermont, it was I believe, upwards of $8,000. Versus at the University of Vermont Medical Center, they have 2 to 3 times as many surveyors. And so you can imagine that cost will increase based on that.
So tens of thousands of dollars per year.
Mm-hmm.
Okay. I appreciated Dr. Merman's questions about serious adverse events. And his question about whether, how to interpret the number. And so I want to check my understanding. My understanding is that when a safety culture is growing, it's common for the number of errors reported to grow because people are more comfortable pointing out errors. But serious adverse events are not expected to grow. Is that correct? Or have I missed something? There's a difference between an error and some errors become serious events, but not all errors.
Right, and I agree with you, and I would say along with that, with an improved or increased awareness of the culture of safety, that you may, through surveillance, become aware of more actual events. So there may be some that you are unaware of, and now by increasing staff's comfort and safety with reporting events, it could be that you actually are uncovering more of the events that actually do reach the patient and are classified as serious reportable events.
Okay, so in the early years, while you're building this just culture or safety culture, the number of errors would likely go up because you're reporting more, but also some reporting of serious events may go up as well.
Yes, that's quite possible.
Okay. What's your interpretation of the rise in serious events like pressure sores and falls?
It's being seen nationally, and it's something that we've actually had I've been in contact with a few other states' patient safety programs in the last few weeks even, and it's something that everyone is following and seeing is the increase, and we're all playing whack-a-mole with the same thing across the country, including all of our hospitals here just in the state. So it's really, those two in particular are ones that folks are really trying to wrap their heads around, and an increased length of stay does not help that at all. So with boarding and you have patients in the beds longer, it's a matter of time before you have, particularly if you have an older adult who's out of their normal element, the lighting is different, there's equipment, there's tubing, and they're just outside of their normal. It's a matter of time before something really might happen.
And may I add that patient characteristics are very different these days than they used to be. The acuity in the hospital is much higher. You have a lot of patients with sepsis, that have huge changes in their metabolism, and their skin is probably the first organ to be impacted. And it's the first organ that doesn't receive circulation when you're very, very ill. And other patient characteristics about our aging population in Vermont, diabetes and heart disease, those are all debilitating illnesses in the hospital that require a lot of medication to keep blood pressures up, to decrease circulation that's not necessary to sustain life. So the patient characteristics, as well as dementia, there's a lot of refusal of care in the older population who is bedbound and confused and not able to work with the nursing staff to turn frequently and to change positions and to use all kinds of assistive equipment to keep them from landing back on their back again. So, and there's also the contributory factor of younger nurses entering the field. We have a nursing shortage that we're trying to bolster with lots of new nurses, but new nurses take time to really understand the whole person concept of care in the hospital. And they, you know, just like any novice will check their checklists, and that'll be it. They don't think outside of the checklist until they have enough experience. And so, you know, of course, most hospitals use preceptors to help the younger nurses along. And I'm not saying that these are younger nurses, you know, like 20 somethings. They're just new nurses to the field, could be of any age group. But all of those factors and the factors of travelers just really, these are, you know, pounding on the safety of patients, especially in the pressure injury area.
Yeah, I appreciate that discussion, because there seem to be patient characteristics and factors and illness severity. That's kind of one bucket. And the other bucket are staffing factors, right? And I think it'd be an interesting quality thing to try to understand which one is driving. If one of these factors is playing a bigger role than another, because the new staff and the traveling staff can have such a profound impact on culture. Right? They haven't been through the same training, local training. So, well, thank you. That all helps. Thank you. I was interested about the peer review network. I don't recall that from last year. How many reviewers do you all have?
I do not have that
Okay.
off the top of my head. Maybe around 6. I need to check. I don't want to speak out.
Okay.
But I can check and get back to you on that.
And is there is the participation with facilities, hospitals and non-hospitals, is there robust participation, or are we still trying to build participation, or what's the status with the peer review network?
That's such a great question, and it's really a black box for us. It's almost a self-serve kind of platform that exists. So hospitals kind of know that it exists and reach out to one another independently. It's very decentralized. So that's kind of part of our goal for redesigning the peer review network, is to try to understand those data points. You know, are there any trends that we should be monitoring and things like that? But right now, it's very much kind of outside of, we don't have insight into, you know, how often it's being used. Just we've done surveys that it's available, and the hospitals that have used it in a time of need find it to be a valuable resource.
Right, because it reminded me almost of like a learning network. The Northern New England Cardiovascular Study Group used to, Vermont, Maine, and Dartmouth used to participate together in that and really drive it. And it was had a similar peer review type of thing. So I was happy to see that, and hope you get some more information out of that black box and make it more robust. I also appreciated hearing about the quality framework. I worked with Allie on that, and I was hoping to hear more about its current status. But along with kind of a current status and what's the most immediate next step, the MBQIP slide, how does that relate to the quality framework? Is it duplicative? Is it separate? In how do those two things overlap, or don't they overlap? Or could we remove some redundancies for folks?
Hillary and I are both waiting for each other to unmute.
We're staring at each other.
I can start.
Okay.
MBQIP measures were used as one of the starting points for inventorying measures and reporting systems that hospitals currently engage in. So that was high on in our minds to avoid duplication. In terms of current and future work, Elena could speak to this too, or Hillary. We are coordinating among FOS and the Healthcare Advocates Office, Green Mountain Care Board, and VPQ. We are looking at the inventory of measures that I described, and right now having a little bit of a quiet time to make space for the hospital budget process. But we've been really, I would say, Emma Harrigan from FOS is driving the discussions, and we are providing technical assistance. Hillary, would you like to add?
No, I think we're that's great, and we're just working to try to figure out what those next steps look like.
So the MBQIP set of measures was examined, and some aspect of it is captured in the current state of the quality framework.
Yes, yep. And so that framework is really supposed to apply to all Vermont hospitals.
Right.
MBQIP is a critical access hospital specific measure set.
Right.
So we pulled from there. If we're reporting those measures, it would just be pulled into the hospital quality framework that Alex has been working.
The framework took all of these inputs that each had multiple questions and aspects, and kind of arrived at a set of 19 measures, if I heard that correctly, right? And so the getting everybody to sign off on agreeing to those 19 would seem to be an important step, and then getting everybody to use them. Is that kind of where things are quiet at the moment, getting everybody to agree?
I think we've stepped back a little bit to reorient ourselves to the purpose for having a set of measures. If we were to have the conversation right now about, don't you agree with these 19 measures we determined 2 years ago were correct? It's we have to back up a little bit and kind of go through a little bit more of those process steps I showed, and then revisit the measures. The thing is, we really need to agree on a process because measures change every year. For example, there's some great new health equity measures available than the only one we had a couple years ago, which was, what is your preferred spoken language, I believe is what we landed on. So I'll leave it there.
Yeah, and I think we try to practice what we preach. We don't want to create a new structure. There are existing structures that have measures that are speaking to the quality of care across Vermont hospitals. So, just a little more time to understand where the best place for this to land is.
Okay.
And I would really appreciate a revisiting of the recommendations, the 14 recommendations too.
Yeah.
Which contain ideas for future collaboration.
Great. Yeah, I think that would be helpful too. Thank you for the presentation and your time and taking the time to answer my questions.
I just have one or two, and thank you all. The Care Board is working with AHS on hospital transformation through Act 167. And one area that hasn't been a focus of that work is quality. And as we consider transformation of hospitals and looking at service line opportunities to ensure sustainability, do you have any information you could bring to AHS and the Care Board and hospitals in terms of quality that would help inform some of those decisions?
Not much over and above what we presented through our programmatic work today.
Aside from that, are there any external or third-party resources that you think would provide the Care Board and others the best information on quality in Vermont? And I guess I'm referring to Medicare Star Ratings or Leapfrog or HCAHPS. Which ones would you guys recommend?
Allie, do you want to, because this was explored through the quality framework work.
I don't want to upset the apple cart. Aggregated sets, so measures that measure a number of items and consolidate it into one measure. And star ratings and other types of ratings that just aggregate a lot of quality don't say enough. I would recommend looking at individual measures, and that's what we did in our quality framework. There's some great a couple of great resources that I can point to on our site, and I'll follow up. But NHANES, New York, well, please help me with the acronym, their quality organization, they did a couple of publications about rural measures and measures that matter, and they rated rating systems. And we studied that as part of our work. I would recommend looking there too.
Do you have any information relating to specific service line quality at hospitals in Vermont?
We don't have an existing contract that would give us that data. We have the patient safety program that we presented on today, and the hospital report cards support that we provide to the hospitals, but we don't have a contract for that, no.
So the Act, do you mean the Act 53 scorecards? Is that what you're referring to?
Yes, yep.
And, you know, unrelated to 167, one thing the board's been working on for a number of years is improving our processes, right? If the state decides that the head model is a productive path to take, we'll want to include quality in that regulatory structure. And even if we don't, we have an opportunity to improve the care board's regulatory process in terms of quality. So we've started work on trying to come up with an affordability standard, which we socialized last summer. Quality is another one where I think we have opportunity. If you have information that we could use or work with in terms of building out our quality assessments to inform our hospital budget decisions, well, let me ask that. Do you have information that you think would be useful in that process?
You know, I think we'd need a little bit more around, you know, what the vision is, the goals and objectives. But we, you know, working with Elena and the GMCB staff, that's, you know, why we've been collaborating, is to see how we can take a strengths-based approach to supporting each other in our work.
Great. Well, we should meet and try to do that, because it seems like you guys might have some opportunities for us to leverage so that we can do a better job in that part of our work. All right. Well, thank you for your time. I have no other questions. I'll turn it to the healthcare advocate.
Good afternoon. Congrats, Hillary, in your new role. Just wanted to thank VPQRC for the presentation. It's been great working with you guys and participating in these various groups, and we look forward to continuing to do that. I hope everyone stays safe with all the flooding that's about to happen.
Thank you, Sam. And I'll open it up to public comment. Ms. Gutwin?
Hi, I'm an independent PT provider and business owner of a PT practice in Vermont. And I'm just curious, a question, is VPQHC only involved in hospitals? Looking at the mission and the title and sort of the framework of VPQHC, I see healthcare system, but the report is just on hospitals. Do you have an equivalent or at least some interest in work with the rest of the healthcare system, how they're doing, like a finger on the pulse of the entire system?
We would love that. Okay, let me start with the fact that the presentation today was just focused on our hospital-based quality improvement work. That we do quality improvement work with all sorts of healthcare providers and organizations from across the continuum of care. And you know, that's on our website that we try to keep updated. You can also find some information in our impact report. But really it comes down to capacity and contracting. We are open. Our mission is to improve the quality of healthcare for Vermonters. So we're very open to partnering with any kind of provider to do quality improvement initiatives.
Thanks. I might give you a call later.
Please do. We'd love to talk.
Thanks.
Walter?
Hi, Ellen. Thanks. I'm just curious, who funds VPQHC?
So our core funding, our 9416 contract, we are established by statute and we receive bill back from the hospitals and insurers. So that supports our core funding contract, but that can't make up more than 75% of our overall budget. So we have a lot of other grants, contracts. We have support from private philanthropy to work on other initiatives outside of 9416.
So when you say throwback from hospitals, that means that it's our premiums, our taxes, insurance money, etc., that goes to the hospitals that's going to you, right?
I wish I had that level of detail. I know we receive bill back and I don't know anything beyond that.
What it is.
Yeah, I think ultimately it's pretty fair, Walter. I think, the state funds hospitals through a number of mechanisms, federally Medicare, state Medicaid, state taxes, commercial insurance, co-pays, out-of-pockets, for sure. And then, yeah, I think that's fair. Any other public comment? Okay, hearing none. Thank you all very much for coming in and for your presentation today and for your work.
Thank you for the opportunity.
Yeah,
Thank
you.
Thank you.
I think that's all we had on the agenda today. Any new or old business to come before the board? Great. And for anyone traveling in St. Albans tonight, please drive safely. And if the weather looks too iffy, please stay home. But if you're able to make it, Robin will be there and I will be there and AHS will be there. And we look forward to seeing the folks who can make it. Have a good night. Thank you.
Thank you all.
I think you need a
sorry.
motion to adjourn.
I know. You're right. I'm in too many different types of meetings now where I forget what I got to do where.
That's okay.
So I will move that we adjourn.
I'll second.
All in favor?
Aye.
Aye.
Aye. All right, now we're adjourned. Thank you.